Hello, and welcome to the 48th Annual AAKP National Patient Meeting. Transforming American Kidney Health, Patients Take the Lead. My name is Lisa Pappas, proud ambassador for the AAKP. I have been living with kidney disease caused by type 1 diabetes since I was diagnosed at the age of 4. This year marks 48 years of living with this disease. I have been a dialysis patient in the past, and I am the blessed recipient of a transplant that has enhanced my life and allowed me to live life to the fullest again. I enjoy spending time with family and friends. I also enjoy creating handcrafted greeting cards. Being an AAKP ambassador has provided the opportunity for me to help by sharing my experience with others. If I can help somebody deal with their kidney disease and their situation and help them navigate a little easier, I will be honored. As an AAKP ambassador, I share the message that every kidney patient has the most important voice in determining their care plan. It's imperative that an environment is created that supports kidney disease research and innovations so that we are continually advancing care, improving treatments, and providing solutions for unmet patient needs. And when those innovations are FDA approved, it's crucial that all patients have access and the right to choose the treatment that's best for them in consultation with their doctors that they choose, so that every patient can live their best life and achieve their aspirations. It gives me great pleasure to moderate today's session titled Understanding the Signs, Symptoms, and Treatments for Renal Vasculitis, a condition that causes the rapid loss of kidney function. We are honored to have an expert with us to give us a better understanding of the condition. We are joined by Dr. Elizabeth Brant. Dr. Brant is a nephrologist and assistant professor of medicine at Geisel School of Medicine at Dartmouth Health in New Hampshire. She is also a board member of the Vasculitis Foundation, an organization that advocates for early diagnosis, better treatment, and improved quality of life for patients living with this condition. Dr. Brant brings us a unique perspective to today's presentation as she herself is a vasculitis patient. Dr. Brant, thank you for being with us today. I turn it over to you.
Thank you so much, Lisa. It's really nice to be able to talk on behalf of the AAKP. I always appreciate an opportunity to talk about vasculitis and renal vasculitis, one of my favorite topics of all times. I will try not to keep you all day. I think it'll be fine. This is sort of my area of specialty. So again, one of my favorite things, and I appreciate you letting me speak today. So I think it's important first, because I know not everyone in the audience here has vasculitis, but to know what are the leading causes of kidney disease. Diabetes, by far, top in the entire world. Hypertension or high blood pressure is the second. If you have kidney disease, there's a really good chance that you have one or both of those. But the third leading cause, if you look at any form of what's called glomerular disease, which would include some forms of vasculitis, those together are the third leading cause of kidney disease. So a really important collection of disorders there. So vasculitis in the kidney. So not every form of vasculitis does affect the kidneys. The ones that do are those that affect small and medium-sized blood vessels. So those that do tend to involve the kidneys are on this list here. Polyarteritis nodosa, IgA vasculitis, which we used to call Henoch-Schönlein purpura, and you may still hear that. That's actually the most common type of vasculitis that causes kidney injury in children, although we do see it in adults. There's cryoglobulonemic vasculitis, eosinophilic granulomatosis with polyangiitis, a big mouthful, so it's easier to say EGPA, and that was formerly called Churg-Strauss syndrome. Again, you might still hear that occasionally. The two that I'm going to focus on today are microscopic polyangiitis, or MPA, and granulomatosis with polyangiitis, or GPA. You'll see that I have written there formerly called, and we do not use the W word. So I don't even use the W word when I'm telling people not to use the W word. You all know it if you're familiar with this disease. So we're going to stay away from that. So when I talk about MPA and GPA, what I'm really talking about is ANCA-associated vasculitis. So ANCA is an acronym for anti-neutrophil cytoplasmic autoantibody. And that is way too many words. So again, we just abbreviate that to ANCA. And to understand what this is those ANCA, again, they're a type of autoantibody, antibodies that your own system makes to something within you. So they're usually not good. So these antibodies are reactive to a molecule called PR3 or a molecule called MPO. And those come from a certain type of white blood cells, or actually two types of white blood cells. And what happens is when the antibodies react to these molecules, it leads to widespread inflammation of the small blood vessels. Does not affect your aorta, which is the big vessel going down the middle of your body, is not going to affect the big blood vessels in your arms or your legs, but it's going to be things like the kidneys, the lungs, sometimes the skin, certain parts of the nervous system, et cetera, et cetera. Kidney involvement in these two types of ANCA-associated vasculitis is very common. And in fact, the kidneys might be the only organ involved, although that's probably a little less common. So I think it's important to mention the nomenclature, because if you have one of these disorders or have heard of them, you might ask, as many people do, well, what's the difference between this and this and this and this and this? So there's the first terminology that I mentioned, which is MPA, or that microscopic polyangiitis, or GPA, the granulomatosis with polyangiitis. That tells us a little bit about these disorders. Another way to name them is to call it MPO positive, ANCA-associated vasculitis. Therefore, you have the antibody against that MPO molecule, or PR3 positive, ANCA-associated vasculitis. Now I'm going to throw in here just a little wrench, which is that in very, very specific instances, people might have antibodies to both. That's not sort of the classical thing that we see, but just to be aware of that. I personally tend to use the latter terminology, the MPO positive and PR3 positive. And the reason I do that, I would say that most people I know actually use the other nomenclature, but the reason I do that is because knowing if you have the MPO type or the PR3 type actually tells me more about how your disease might behave. You could have two patients walk into the room who are exactly the same. For all intents and purposes, they are identical twins. They both have vasculitis. They both have whichever organ involvement. One can be MPO, one can have PR3, and they might have a different course with their disease. So that's a little bit more helpful to me. So how do these diseases, these forms of vasculitis, get diagnosed? Well, for renal involvement, one of the most important things is usually that we get a kidney biopsy. There are blood tests that help with that diagnosis, but just to throw yet another wrench in the works, some people have one of these forms of vasculitis, but that MPO or PR3 does not show up in the blood. So you can't be quite sure. We really like the kidney biopsy for multiple reasons. For one thing, is it just vasculitis? Believe it or not, you can have vasculitis and at the same time have another disease affecting your kidney. That is not what usually happens, but it's not so infrequent that we don't think about it. Another thing that the biopsy does for us is it tells us how severe is the injury. So to give you an example, I might biopsy somebody and I see horrible, horrible inflammation. There is just almost no part of that biopsy. Bearing in mind, these are little tiny, tiny, tiny pieces of tissue. But in that little bit of tissue that I see, I see almost nothing that looks normal, but it's all inflamed. Or I do a biopsy and I see the tissue doesn't look normal. It looks really scarred. Well, the first one of those, where there's a lot of inflammation, that's a really severe injury. However, it's treatable. as long as there's something active inflammation, active disease going on, that is potentially reversible or at least partially reversible. Whereas if it's just scarring, we just have poor, sad, scarred kidneys, the prognosis there is not as good. I'm not going to be quite as optimistic. So we've gotten our diagnosis, we've gotten blood work, we've been told we have kidney disease, maybe our kidney function isn't normal. It's typically not going to be if you have one of these disorders. So then what do we do about it? The mainstay of treatment is immunosuppression. For those who aren't familiar, that means drugs that literally shut down, not entirely, but suppress your own immune system. Remember that I mentioned that the problem here is that your body is making antibodies, which we do all the time. They usually fight off infection. They actually help us fight cancer. But sometimes things go awry and we make these antibodies that attack things within us. That is no good. So we want to quiet down the immune system for a long period of time. And then if we lift the immunosuppression eventually, that the immune system has kind of reset itself and we're no longer making these sort of detrimental antibodies. We sort of split the treatment into a couple of phases. The first phase is called induction, and the second phase is called maintenance. You might have heard similar terminology when you've spoken with somebody about cancer therapy. The induction phase is where we just work on getting that disease in remission. What do I mean? I mean that there's no evidence of active disease. The inflammation is gone. There may still be injury. The kidney function may not be normal. Any other organs that are affected may not have recovered yet, but the underlying problem is quiet. That's the induction phase. We don't stop there. We then go on with maintenance therapy because you might need a few weeks or a few months, maybe longer, to get into remission. Sometimes it's challenging, but we want to do maintenance therapy anywhere from 2 to 5 years so that when we finally stop the immunosuppression, your immune system has had plenty of time to reset and you don't make those antibodies. The longer we do that maintenance therapy, up to a point, the less likely you are to have a recurrence. There's the dilemma. These diseases, as I tell my own patients, these are for a lifetime. This is not treat it, you're done, go on your merry way. My poor patients, I tell them, sorry, but you're stuck with me forever now. One of us has to retire before you get away from me. So these diseases can flare. Again, going back to that MPO versus PR3. My MPO patients are probably not going to flare as often. My PR3 patients probably are going to flare more often. There's not any hard and fast rule. That's just sort of generally what we see. Let's say you do flare. Is the world going to come to an end? Probably not. Not if you catch it early. And guess what? We just do the same management over again. We do another induction phase, get you in remission, put you on maintenance to whatever period makes the most sense in your situation, then take it off and see how you do. If you're somebody who flares very often, you may get a longer period of maintenance therapy to see if we can prolong that period of remission. It's going to vary from person to person. Well, so what do you do after the diagnosis besides just treatment? So looking specifically at the kidney function, some terms that will be very helpful to you. Some will be very helpful to you even if you have another form of kidney disease. So I want to talk about those and how we determine the kidney function. So one term that is fairly specific to ANCA-associated vasculitis and perhaps one other form of autoimmune kidney disease is called rapidly progressive glomerulonephritis, RPGN. I think you're starting to see why we use a lot of letters. The words are just too long. So to break that down, I think rapidly progressive is pretty obvious. It gets bad really fast. Glomerulonephritis, that big word, glomerulo refers to the word glomerulus, which are the little filters in the kidney, the glomeruli. That's just the plural. Nephritis, neph is kidney, and itis is inflammation. So you have inflammation in the filters of the kidneys. That gets bad, comes on quickly, gets bad very fast. Rapidly progressive glomerulonephritis, or RPGN. So that is often what we will see with renal vasculitis. So vasculitis specifically affecting the kidneys. That obviously only refers to the kidneys, not any other organ. There's another more general term called acute kidney injury, AKI, or acute renal failure. We tend, this is just a little historical point, we have tended to move a little bit away from the phrase acute renal failure because it has the word failure in it, which can be just very disturbing to people, including me. So we say acute kidney injury, meaning it's happening right now. It's an injury, but we're going to see if it's going to get better. Your kidneys aren't necessarily permanently failing. But if you hear either term, don't panic. They mean the same thing. So acute kidney injury came on recently, and we're not necessarily going off like a freight train like the RPGN, but it is happening right now. Let's say your disease is in remission, but you are left with less than perfect kidney function. Now we're talking about chronic kidney disease. The word disease, again, a little weird because it doesn't mean that you have that active thing that was causing the disease necessarily, like vasculitis. Now, if you have high blood pressure, diabetes, you probably do still have those. But chronic kidney disease, meaning the kidney function isn't normal, it isn't perfect, and depending on how severe the renal insufficiency is, renal, same as kidney, then we determine the stage. But we can't determine what stage of chronic kidney disease is until the kidney function is stable. If it's fluctuating, it might look like CKD3 one day, CKD5 one day. We don't do that. We wait until everything is stable, and then we go from there. So how do we figure this out? The most common thing is what we measure in the blood is something called creatinine. Now, creatinine comes from muscle. It's perfectly normal. Our muscle cells, we have ones that die off, we make new ones, and they release this substance called creatinine. Completely benign, does nothing. Well, our muscle mass, any person's muscle mass generally doesn't change from one day to the next, right? If you're just, today is Tuesday, tomorrow is Wednesday, you have the same muscle mass unless something really horrible happened. So the creatinine, that what we call cell turnover, happens at a regular pace. You release stable amount of creatinine all the time. And so the level of the creatinine in the blood should be pretty stable. A little bit of fluctuation, but nothing severe. So we then, if we see that that creatinine level in the blood is rising, we know that there's a problem because the kidneys filter out that creatinine. It goes out in the urine. So if the creatinine is rising, we know there's a problem. Higher the creatinine, the lower the kidney function. Important relationship to remember. So we use that creatinine to calculate an estimated glomerular filtration rate, or eGFR. You remember glomerular from up at the top, which is just the filters in the kidney. Duh, filtration, that makes sense. So it's what's the rate at which the kidneys are able to filter? If the creatinine is high, that rate has slowed down. There's another thing that is a more precise measurement. It's not an estimated rate. It's a measured rate called the creatinine clearance. For that, you need some blood work and you need some urine studies. And based on the results from those two things, you can calculate the creatinine clearance. It's kind of a pain. For those of you who have done a 24-hour urine collection, you know exactly what I'm talking about. You have to collect your urine for 24 hours. You have to put it in the refrigerator. You just hope you don't make a mistake and think it's the bottle of orange juice, okay? So there you go. eGFR, what we most commonly see, usually quite good, except for some kind of extreme circumstances. Creatinine clearance, if we don't believe that we're getting a really good estimate of the GFR. And there are a couple of other ways, but this is the most common. So my kidneys are injured. How am I going to heal them? And if I can't completely heal them, how am I going to preserve the kidney function that I have? This is probably, in addition to just treating your disease, this is the big thing. Every single patient I see, every single patient, no matter what's causing their kidney problems, what can I do to help my kidneys? What can I do to help my kidneys? So that's kind of where we're going to go now. The first and obvious thing is if you have vasculitis, you treat the vasculitis. To be very clear, vasculitis will not go away by itself. It's not that kind of disease. Some things, we get certain infections. Some infections will clear up on their own. This is not that. This is a very, very serious disease, no matter what organs it's affecting, and it has to be treated. What else can you do? Follow with a nephrologist. That's a kidney specialist. I do not say that out of self-interest. I don't have to beg for patients. They're coming out of the ward work where I work. The reason I say that is because we have a particular capability, because of what we do, to interpret the studies, to monitor the kidney function. We, at many locations, including mine, we're able to literally get a urine sample from you in clinic, go right around the corner to our little lab where our microscope is, look at your urine under the microscope, and it will tell us, or at least give us clues, is your vasculitis still active? Does it look like things are cooling off? Is it better? Or does it look like completely normal urine? That's what we're hoping for. You also want to avoid other causes of kidney injury. You don't want to have something else compounding the big problem that you have if you have vasculitis. So what did I mention at the beginning? What are the two biggest causes of kidney disease? Diabetes, high blood pressure. You must get those under control. Go to whomever you need to do that. If your primary care provider, if you have really bad diabetes and they're not comfortable taking care of that, if you're able to get in with a diabetes educator or an endocrinologist, great. But work really hard to get that under control. High blood pressure. Nephrologists actually manage high blood pressure. So your nephrologist should be able to work with you on that. Other people can too, but it's nice to kind of have the one-stop shopping there. Avoid medications that can injure the kidneys. Probably the single biggest thing are NSAIDs. What does that stand for? Non-steroidal anti-inflammatory drugs. More letters. I just have a few of them listed, but these are kind of the common ones that I suspect everyone watching has seen or familiar with. Ibuprofen, Motrin, Aleve, Advil, naproxen, meloxicam, Toradol, ketorolac, and on and on and on. Stay away from them. They're wonderful. I understand that. Everybody says, but that's the only thing that works. I get it. They are anti-inflammatory. You have an inflammatory condition. However, in this instance, you run the risk of really causing significant injury. If you feel like you need a non-steroidal, talk to your nephrologist and see, can I take them at all? Can I take a little bit? How much? That sort of thing. Another sort of big category, particularly if somebody's in the medical system, still getting a lot of procedures and studies and things, is to be careful with what we call iodinated contrast. That's contrast with iodine in it. Most people refer to it as dye. CAT scans often use dye to help the images be more clear. And you have to be very careful with that if the kidney function is low. Most radiologists or radiology departments actually kind of monitor that and will say, wait, this person's creatinine is whatever, their GFR is whatever. Are you sure you want us to do this? But don't rely on that. If someone orders for you, any provider orders for you a CT scan, ask them, is this going to be with contrast? Is it going to hurt my kidneys? If your kidney function is normal, it should not be an issue. And as long as there's no reason that you can't drink plenty of fluids, like you have heart failure, you have to be careful with fluids. But if you're otherwise pretty healthy, just make sure that you're well hydrated before you get that contrast and after you get it. That'll help it clear out. It's important to distinguish this from the contrast that is used for an MRI. That's different. That does not affect the kidneys. The MRI is fine. Potential cause of some other problems, but not injuring the kidneys. It's okay. Another sort of drug class that we've, in the last 10 years or so, have really started to recognize as potential culprits for causing kidney injury on their own are the proton pump inhibitors. Many of you have heard of them. Many of you are probably on them. Those are medications that help suppress stomach acid. People take them sometimes for heartburn, but those would include words that end with that azole you see there, pantoprazole, omeprazole, etc. I don't want to vilify them as medications, but they should not be used lightly. I tell patients, I will ask them if they're on one, what are you taking that for? I have heartburn. You don't need that for heartburn. Try these other things. Talk to your PCP. If you have had a GI bleed, yes, if you've had an ulcer, for example, in your stomach or in your small intestine, you need those. You stay on them. That's just not optional. So at least be aware if you're on them. And if you are, talk to your nephrologist or your PCP. And the next thing, nobody wants me to talk about this, but I have to, is obesity. Believe it or not, obesity by itself, if you had no other medical problems, obesity is a risk factor for kidney disease. You're just asking, the way I like to describe it is if you weigh a lot more than you should, you are asking your little kidneys to do extra work. I compare it to putting a Mini Cooper engine and an 18-wheeler. It's not going to go well. Eventually, that little bitty engine is going to give up on you. So, and I know it's not a fun subject to talk about. That alone, I could literally talk about all day. Just be aware of it. Again, talk to your nephrologist, talk to your PCP. If you have a weight clinic, dietitian, there are a lot of options there to help with that. It's hard. I know. I got it. And then if your kidney function is low enough, sort of the more advanced stages of kidney disease, you can develop complications purely as a result of having kidney disease. These would include things like anemia, problems with vitamin D, phosphorus, calcium, on and on and on. Your nephrologist should be able to manage all of those. And if you really meticulously manage those, it will help keep your kidney function as stable as possible for as long as possible. And you're going to want to do that. So let's talk a little bit more about that chronic kidney disease and those complications that I was mentioning and what can prevent your chronic kidney disease from regressing or help keep it stable. It does not matter the cause of your chronic kidney disease, your CKD, vasculitis, diabetes, hypertension, you don't know why, but you have it, that kind of thing. So again, I'm going to harp on the diabetes and hypertension. Make sure those are well managed. Anemia, in brief, your kidneys make a hormone that helps you to make red blood cells. It's the hormone that goes to your bone marrow and stimulates it to make red blood cells. When the kidney function declines, all of the functions decline, including that one. So sometimes you may need iron. Sometimes you may need an injection of that, a synthetic version of that hormone. Again, your nephrologist can manage. We refer to a sort of a general category of bone and mineral metabolism. That would include things like calcium, phosphorus, something called parathyroid hormone, that is not the same as thyroid hormone, vitamin D and uric acid. These are all related in a slightly complicated way. The short version is to say they can all become abnormal, a little deranged in the setting of chronic kidney disease, and you're going to want to manage those, not only to preserve your kidney function, but to also protect your bones. Electrolytes, particularly potassium, tends to want to get elevated in most patients with chronic kidney disease, at least at the more advanced stages. So talk to your nephrologist about dietary considerations or the medications that you can use if absolutely necessary to help control that. Cholesterol might seem a little odd, talking about kidneys, I'm talking about cholesterol, people think heart disease. Having chronic kidney disease is what we call a cardiovascular risk equivalent for developing heart or vascular disease. So it's the same, having chronic kidney disease is the same as having had a heart attack, having had a stroke. It's the same in terms of risk for having something else bad happen. So we try to control the things we can because we're controlling, as all the things I mentioned above. But cholesterol is something that we can usually control. So it is generally recommended if you have chronic kidney disease that you be on medication for cholesterol, even if your cholesterol levels are normal, believe it or not. And that is because the association of chronic kidney disease with developing, for lack of a better word, hardening of the arteries is so great that we like to sort of preemptively get in there and treat that. And one of the last things is what we call acid-base or acid-base disorders. With chronic kidney disease, we tend to have excess levels of acid in our blood, and our kidneys would normally balance that out. They kind of can sort of lose that ability. And you want to manage that so that you don't have excess acid. We know that if you do, we call that acidosis or acidemia, emia meaning in the blood. We know that that by itself, again, is a risk factor for your chronic kidney disease getting worse. So very, very easy to treat, very important to treat. What about general health maintenance? What do I mean by that? Now, remind myself that we're talking about vasculitis specifically. I would say this also applies to having chronic kidney disease more generally speaking, but if you have vasculitis, your immune system is being suppressed. Guess what? You are at risk for various infections, more so than the average person. So you should not get, while you are immunosuppressed, you should not get live vaccines. These are vaccines that have a little component of live virus in them because you will then get those viruses. Something called zoster, which is the same as shingles, MMR, if you remember that from childhood, measles, mumps, and rubella, varicella or chickenpox, yellow fever. Those are ones you should not get while you're immunosuppressed. You should get your flu shot every year. You just should. There's so many things I could say about that. Strongly recommend it. Pneumonia. There are actually 2 different shots to help prevent a specific kind of pneumonia. It's a very bad pneumonia. And the dosing schedule is very specific. That's something you can get probably through your nephrologist or through your primary care doctor. Make sure you're up to date on tetanus. We've all had it at some point. If it's been more than 10 years, you need to get that booster. If you're of the right age, you should get a shingles vaccine. However, notice I put up there, don't get the shingles vaccine. It's because I'm trying to trick you. No, I'm just kidding. There is the older form of the shingles vaccine that has live virus in it. There's a newer shingles vaccine. It's actually, I believe, a series of at least 2. It's called recombinant. It is made without any of that live virus. That is okay. Hopefully I don't have to say get a COVID-19 vaccine. If you've had the vaccines, get the booster, stay up to date. You don't want to add that to your troubles. Ideally, you would want to get these vaccines before you start your immunosuppression, or if you've already started, sort of between doses. Just to briefly say, one of the medications we most commonly use is usually given about 6 months apart. It's an infusion, IV medication, and it's given about 6 months apart. So if you haven't had them, when it's getting to be time for that next infusion, go ahead and get your vaccines then. If you only get them when you're in the middle of being immunosuppressed, your immune system is not going to respond to the vaccines. So they're not going to be terribly effective. So you may need other vaccines. Again, discuss that with your PCP, depending on risk factors that you have, your PCP, your nephrologist, and just make sure you're on top of those. Another very important aspect of health maintenance, I mentioned earlier that our immune system also helps us fight cancer. So you want to make sure that you get your age-appropriate cancer screening for that. That's one reason. So if you're female of an appropriate age, mammogram, family history, it changes that age, do that. Men, prostate cancer, colon cancer, If you're a smoker, have ever been a smoker, get at least a chest x-ray, if not a CAT scan. If you've been on a medication called cyclophosphamide in the past, that's a drug that was previously used very commonly for vasculitis, not anymore. Still used somewhat, but just not as frequently. But if you've been on that for any reason, including vasculitis, look for bladder cancer. Not suggesting you're going to have any of these, but you want to rule them out. A couple of reasons you need to treat them, obviously. The other reason is that, again, your immune system helps you fight off cancer. So we don't want to suppress your immune system if you currently have one of those cancers. It's not going to help out. And you're just going to want to address it. That's all. You're just going to want to address it. What else do you need to do to manage the disease itself? Now we're getting to the nitty-gritty. First, you need to find the right doctor. You want someone who's experienced with managing vasculitis. We're out here. We're everywhere. You want somebody who's going to be responsive to you. Like the vasculitis is very, very serious. I mentioned that before. It's very serious. If you are not feeling well, you need to have someone that you can call and say, I'm not feeling well and I don't know what's going on. It's not your responsibility to figure out, do you not feel well because there's something going on with your vasculitis versus something else. Now, do be realistic. Do not send your provider a message in your patient portal on the computer and an hour later call and say, I sent a message, I haven't heard anything yet. If it's urgent, call, tell secretary, whomever, that it's urgent. And they will track somebody down for you, your own provider, or if that person's not there, somebody else. So be realistic, but you can't have somebody that you can't reach for, 2 or 3 weeks. That's not going to work. You also want somebody who's going to be collaborative. The primary specialty of that provider does not matter. I'm a nephrologist. I manage a lot of vasculitis. I manage patients with vasculitis who don't even have kidney involvement. That's just part of my specialty. A lot of rheumatologists manage vasculitis, some pulmonologists, on and on and on and on, lots of people. Ideally, what you want if you have multi-system disease is you want people that are going to work well together. You can't have somebody saying, no, this is my specialty. I don't need your help. I don't do that. A good team will not do that. So whether the person mainly treating your vasculitis is a rheumatologist, if you have kidney involvement, I still recommend that you have a nephrologist. Vice versa, if your primary person is a nephrologist, but you have other organ involvement, if you have lung involvement, have a pulmonologist. If you have joint involvement, for example, rheumatologist. And frankly, as a practitioner, it's a lot more fun to practice that way when you get to work on patients together. Because not every specialist is going to have a lot of familiarity with treating vasculitis. Probably everybody's heard of it, but they don't necessarily see a lot of patients with it. It is okay to get an expert opinion at one place, but be followed regularly by someone closer to you. For example, I might have somebody who comes from Montreal. I'm actually surprisingly close to there, who comes to see me to give recommendations for their treatment. But they have a regular nephrologist or rheumatologist or both where they live. I send my note to them and say, here's what I would recommend doing. And they implement that plan, or they don't. Or they call and say, I wasn't sure about this. Those are okay. So don't feel like you are, if you get a second opinion, that you're betraying anybody. If you have something unusual, it's really helpful to get someone who's experienced. Be willing to follow the recommendations. I am all for patients having autonomy and everything, but I would say most providers aren't making recommendations just for the heck of it. We are making these recommendations collectively to make you as well as possible. So be receptive. Don't go, oh, no, I'm not going to take that medication. And I'm not going to take that medication. And I'm also not going to take that medication. Because then we're all going to wonder, then why are you here? Just say it. So kind of be receptive to that. Be very attentive to flares. When you are first diagnosed, you are not going to have any idea, particularly when you're having a flare, unless it's behaving exactly the same way it did originally. It may be that you first came to attention because you were really sick. It's entirely possible. Well, I don't want you to get really sick again before we realize that your vasculitis is flaring. So there are some tools, particularly when it comes to renal vasculitis, that can help you. I always recommend to my patients that if you're in remission, very clearly in remission, and you don't have any blood in your urine, you don't have any protein in your urine, or if you do, it's only just a tiny trace amount, you can buy urine dipsticks, those little sticks that they use at the doctor's office. You can buy them online. They're pretty cheap. Pee on a stick once a week. And if you see that, oh, wait a minute, now there's more than trace protein, there's more than trace blood, you call the doctor immediately. Immediately. Notice the next line. If you're not sure if something is wrong, call. That dipstick is going to be one of your first clues. If you only have kidney involvement, it will be one of your first clues, and you can get on top of that before it gets out of hand. If you've already had some chronic injury from vasculitis, you don't want more injury. Don't wait. That's my suggestion. How do you achieve your well-being? Now, particularly for patients who have what we call systemic vasculitis, meaning they have more than one organ involved, they tend to be very sick at some point. Even if you just have kidney involvement, you might have really severe kidney involvement. It's a long process to treat that, to get it in remission, to make sure you stay in remission. It can be frustrating, it can be depressing, it can be exhausting. So you have to think of your overall self, not just your kidneys. What I tell my patients, I told you, they all ask, what can I do to help my kidneys? One of the greatest things you can do for your kidneys, for your entire body, is to have good nutrition. Some of it's common sense. You know that a carrot is better than potato chips. I love potato chips. I get it. There's some common sense. And then there's some stuff that maybe really isn't as common sense as we all might think. So again, if you're not sure what to do, talk to one of your providers, your nephrologist, your rheumatologist, your primary care, and say, where can I go to get more information? And they may be able to refer you to a nutritionist or a dietitian to help with that. Make sure that you're active. I'm not great about exercising myself. I'm usually pretty busy and active, but not in that way. But make sure you're moving around as much as you can. It doesn't have to be the gym. I hate the gym. Take a walk, breathe some fresh air, but keep yourself moving. Have fun. When you have a chronic illness, which is what this is, even if you're in remission, you can't just pretend like you never had it before. Don't make that the focus of your entire life. Have some fun. Because this can be sort of a consuming disease to deal with, at least initially, make sure that your mental health is okay. I tell people that sometimes the process to getting to remission is so long. Again, more often for patients who have more organ involvement, but even with kidney involvement, it can be a little grueling. And you feel like, man, am I ever going to be better? Am I ever going to feel better? And that can be depressing. But allow there to be one little teeny tiny space in your brain that does not get overwhelmed, that says, yep, it's coming, it's coming, it's coming. Just keep at it. It will come. And also make sure that you maintain healthy relationships and healthy boundaries. That may mean different things to different people. If you have toxicity in your life, we all know, we've all had it. Limit that, get rid of it to the best you can. Sometimes when you're sick, people will want to get in your space a little too much, kind of hovering. You may not want that. They want to go to your appointments with you. They want to hold your hand. Maybe you don't want that. Be willing to say, okay, I just need to, do this by myself. I appreciate it, but, go away. You'll find something more diplomatic than that, I'm sure. I mentioned finding the right doctors. Well, how do you do that if you don't know? This is new to you. You ask. Ask your primary care doctor. They can probably at least get you to a specialist. You can call the Vasculitis Foundation. I'm involved with that organization. Fantastic. Take a look at their website. It's vasculitisfoundation.org. They actually have lists of providers. You can see if there's someone in your area. If you don't see anything, you can call there, and because they know a lot of us, they can reach out and say, hey, can you give some recommendations for someone in your area? And if you live near a large medical center anywhere, you can often call there and say, hey, do you have someone who specializes in this? You might be able to find that information online even. I would suggest if you're going to do that, maybe don't call with the main operator. Or if you do, ask specifically for, if you have kidney involvement, say, may I speak with someone in nephrology or rheumatology, whatever is going to be the best fit for you. But obviously for kidney stuff, I have patients who will call sometime and say, I need to see somebody about my vasculitis or my whatever disease. And our secretaries, for example, know, and they'll just come right to me and say, hey, I've got a patient calling, but they don't have a referral. And I go, I don't need a referral. I need the records, but I don't need a referral. So be bold and be brave and just make the call. You'll find somebody. What do you need to feel better? Now, I distinguish this a little bit from what do I need to treat my disease? Because you can treat your disease and still not feel very well for some time. The first one is obvious again, get treatment. Because until you get rid of the disease or get it in remission, you're definitely not going to feel better. Steroids, corticosteroids, things like prednisone, methylprednisolone, those things are always part of the treatment of vasculitis. Limit your exposure to that. We now have a lot of data showing that people don't need to be on steroids for years and years and years and years for this disease. Usually a few months is adequate. So bear that in mind and be willing to talk to your provider about that. Hey, how long do I need to be on these? Do you think we can make it less? What do you think? If possible, have support, be receptive to support. Not those people I was talking about who are too clingy and hovering, but the people who are like, hey, do you need a ride to your appointment? Accept it, right? Maybe you're not going to feel well, and be nice to be chauffeured. Somebody says, oh, I'm going to bring you dinner tomorrow. Take it. Be willing to accept help. It can be very hard for some of us. Manage those other health issues. Again, diabetes, hypertension, whatever it is, heart disease, vascular disease, liver disease, any disease. Just make sure you don't forget that your kidneys are part of a whole body and you have to keep an eye on all of it. This next one might seem a little weird, but I say keep your life even when you don't feel like it. There will be days where you might not feel like doing anything, frankly. Try to do it anyway. If you have a dog, walk the dog. You're not going to want to. You're going to be like, is there any way this dog could walk him or herself? No. Get up and walk the dog. Get up and have a little something to eat. Make your bed. Put some clothes on. Little things. But don't, and think about other things. Find things that you normally enjoy. Keep doing those things. This doesn't have to be the only thing that you think about and the only thing that you do. Otherwise, it'll make you a little crazy. And this last one, which may be the strangest thing of all, use this as an opportunity. I am telling you that this serious, very serious autoimmune inflammatory disease that's going to require a lot of treatment that you're going to have to keep an eye on for the rest of your life could be an opportunity. What in the world? I have lost my mind. I actually have not lost my mind. Sometimes, I will tell you, this is a theory. I have no study to prove this to you, but in my experience, most people who get vasculitis were very healthy before they got vasculitis. It's to the point that it's a little weird to me, in fact. I describe it as I was sitting on my front porch minding my own business when the bus ran over the curb and just slammed right into me, right? They were feeling good. Maybe they had diabetes. Maybe they had high blood pressure. Maybe they had a little this, a little that, but they're overall quite healthy. This can be very shocking. Like, I went from a person who took 1 blood pressure pill a day to now I'm taking 10 pills a day. Doesn't mean you're going to be on those 10 pills forever. Like, what? I'm not a healthy person anymore. Well, you're going to get there. It's going to take time. But use this as an opportunity to say, hey, what are ways that I could be taking better care of myself? Whether that's better care of my mental health, my physical health, my emotional health. I don't want to get to touchy-feely or anything, but I'm just saying sometimes this might be the eye-opener that you need to take better care of yourself. What do you need to know to have hope? Again, it can be a long process. If you have kidney involvement alone, sort of great that, your whole body isn't inflamed, but it can still be really bad. It can still be really hard. And it can be so long dealing with it that you just get tired of it. You may have kidney involvement now, doesn't mean if you flare, you can't have some other involvement. Your lungs get involved, your skin gets involved, your whatever gets involved. So it can be a little overwhelming. So how do you say, whew, I can get through this. It's going to be okay. The first thing to know is that there are really good treatments for this disease, really good treatments. So if you've got a good provider who knows how to manage this, if you work with them, if you've got your good support system, if you take good care of yourself, good treatments, I think that's a great reason to have hope. You will feel better. It will take time. Some patients who feel better literally in a matter of days, they go on steroids. You don't even have to have anything wrong, and steroids will make you feel better. No kidding. But if you've experienced this already, you know exactly what I mean. However, you come off the steroids, you might not feel quite so peppy for a while. You'll get back to it. Again, keep doing those things that you like to do those things that are good for you. You will continue to feel better and better and better. And again, save that one tiny part of your brain that can keep telling you that, even on the worst possible day. So that's all I have for now. I could talk about vasculitis all day, but I won't. I really appreciate you listening. If you have questions, again, reach out to the AAKP. They know how to get to me. Look at stuff on the Vasculitis Foundation website. And if you think of anything, don't hesitate to let me know. I really appreciate it. Bye.
Thank you, Dr. Brant, for an excellent and informative presentation. On behalf of AAKP, I appreciate you sharing your time and expertise with us. We look forward to further collaboration with you and the Vasculitis Foundation.